Hi, I'm Dr. Mark Halstead. I am a pediatric sports medicine specialist at St. Louis Children's Hospital, and will be presenting to you today on sports-related concussions and where are we in 2022. So kind of give everybody an update so we can all be on the same page. So to start off, if I have no disclosures. So objectives today are to modify your current practices in sport concussion care to more of the current evidence-based guidance that is out there, and ways to appropriately counsel your patients on methods to facilitate recovery following a concussion. So I think it's helpful to just frame things first, just talking about the issues related to concussions. So the first concussion and sport group consensus statement, and this is a group that was put together by the International Olympic Committee, the IOC, and FIFA, the Federation for International Football Association, or soccer from an international standpoint. And they brought together experts to come up with a consensus statement on how we should deal with concussion in sports. And the first one was published in 2001, and we've had now a total of 5 statements, and there will be a 6th. There's a meeting to be held in Amsterdam this fall. It's been pushed off, obviously, because of COVID. The last couple of years, we've been due for an update. So we hopefully will have some published guidance and the 6th edition of the Concussion and Sport Group Consensus Statement probably in early 2023. But it's been a long time since that first statement was published. There's been a humongous amount of research on the area of concussion, a lot of it in the world of sport-related concussion since those 20 years have passed, which makes it really hard to keep up on the current guidelines. And unfortunately, that means many clinicians that aren't doing things like me as a specialist on this regularly. It's hard to be up to date with your current guidance that's there, and a lot of people are providing outdated guidance. And because of that, there is this potential for iatrogenic reasons for a longer recovery, because we're using things that we know that actually can prolong recovery rather than facilitate recovery, and we will talk about that. And we know that many myths that are still propagated out there in the world of concussion have been dispelled through research, but they're still being used. So we'll touch on some of those as well. I like to always have a definition, a working definition of concussion, and this one does come from the Concussion and Sports Group, and I think this is a helpful framework to think of things of concussion in general. This is sports related or not sports related, but first off, it's due to a direct blow to the face, the head, the neck, or importantly, elsewhere on the body with an impulsive force to the head. So that may mean someone takes a blow to their chest or their side and they get maybe a whiplash effect to their neck and head, and that can produce a concussion even though they didn't have direct trauma to the head. So we need to be thinking about other ways of getting concussion rather than just a direct blow to the head. So that's where getting a history on mechanism is really important. There is a rapid onset. So typically that day of some symptoms of a short-lived impairment of neurologic function that will resolve on its own. So for most concussions, we don't have to do things to treat them in order to get them better. We may give them appropriate guidance in facilitating their recovery. But in the big picture of things, this is something that generally is going to resolve on its own and isn't something we expect to last for a long period of time. The rapid onset I'll put in there as well. We can see some delay of symptoms, even up to 24, 48 hours. Usually there's going to be some symptoms that are there, but they may have some symptoms that we don't see for the first couple of days. But if someone has a hit and they had felt perfectly fine for a full week, and then a week later they start to have troubles and there was no new trauma, that's not how concussions behave. That would not be fit the definition for a concussive injury. The acute symptoms are due to a functional disturbance rather than a structural injury. So we're not seeing swelling or bleeding or bruising on the brain. That's the reason for a concussion. It's the brain's not functioning properly afterwards, which also goes along with part 5, or the 5th part of this is typically associated with grossly normal neuroimaging studies. So CAT scans, MRIs aren't very beneficial and helpful in assessing concussion. And then that 4th one there that I skipped over there, it results in a graded set of clinical syndromes. So we kind of joke in the world of concussions that concussions are like snowflakes. No two are alike. So even in that person, if they have different concussions at different points of their life, they can have a completely different spectrum of symptoms, different duration of recovery. So again, there really are not things that we would expect to have, kind of a progressive effect. We don't tend to see, which is one of the myths, that you have one concussion and then the next one's going to be worse, the next one's going to be even worse, the next one's going to be even worse. That's not how they typically behave. And they may or may not involve loss of consciousness, and we'll talk about that in just a second with regards to symptoms. So if we look at just the common sports that are out there for concussion, you'll notice that some of these sports here only have a single or a couple bars That's because some of those sports like hockey and lacrosse here are more regional sports. So when they do the epidemiologic studies for these, they may not have athletes participating in this research. But as we would expect in male sports, football tends to be the one that has the most predominant frequency of concussions in sports. And these are based on what we describe as an event per athletic exposure. So an athletic exposure would be a practice or a game, and these are typically graded as 1,000 athletic exposures. So football would have 0.7 concussions per 1,000 athletic exposures. We see hockey and lacrosse are smaller. Wrestling and some of the more recent studies suggest that the rates are actually higher than what were previously reported, which is not unusual if you're familiar with the sport of wrestling. There's a lot of hiding of injuries that occur there, hiding of skin conditions, because those can disqualify people. So it's kind of a culture, unfortunately, in that sport. So we do tend to see some of that happening. And so some studies have suggested that the rates are higher and may get closer to that football range of concussion. Okay. So when we look at female sports in here, obviously soccer is the one that is the most predominant here. We don't tend to see a lot of female athletes playing football. There are a select few that are out there, but not many of them. So we don't really have data for female football players. But interestingly, in some of the more recent studies here, soccer actually has a fairly high rate that even rivals football in these couple of studies. And then we see kind of a hodgepodge here of other sports of different rates of concussions, but nothing rivaling soccer as far as the most recent ones. Basketball is up there, lacrosse as well. I'll bring attention to cheerleading here because there's only a couple of bars here for cheerleading. In Missouri, we are required to mandate reporting of concussions at the high school level. It's part of the state law that was passed over a decade ago with regards to mandated education. And then also there was mandated reporting to the Missouri State High School Activities Association. And so we keep track of this, and we have annual reports on concussions that are reported from high school. And we actually have a very good response rate in the 80s to 90 percentile, or 90% of schools report their concussion data. And cheerleading is actually number 3 of all sports. That's males and females for concussions in the state of Missouri. So we have to be aware of that there may be, again, some of that's kind of underreported a little bit in the sport of cheerleading. So if we look at common signs of symptoms, as you would expect, there's a variety of them. There's not one symptom that identifies concussion alone. So we group them into physical categories, symptoms, cognitive categories, emotional, and then sleep. Obviously, for sleep ones, we're not going to see those in the acute setting, but we may see those after a day or two where people are starting to have some difficulties with their sleep. Either they're sleeping more or less than usual, troubles falling asleep. But it is important to ask about these symptoms, and we'll talk about ways that you can facilitate that a lot easier than just asking the person about them, because if it's an athlete, their odds are they may not be honest with you if you ask them a yes or no question, because it's easy for them to say no, similar to the sports physicals where they can just check off no for everything, and they may or may not look at the questions. So we need to be asking about these individual things, because it's not just headache, and we can't just use headache alone as an isolated symptom that identifies whether someone has a concussion or has recovered from a concussion. So how do we do things in office for assessment? History taking is always important. I think it's really critical to get details of the event, the symptom onset relative to the injury. Did it happen immediately? Did it happen a little bit later on? An important question to ask about is, did they play through it? And the reason why that's really relevant here is we know from research, and we had seen this in our offices anecdotally for years, but someone actually finally put the research to it, and it's been replicated in several studies now, that athletes that stop immediately compared to those that continue to play, those that stop immediately have much less symptoms, and actually their recovery time is half of what it takes to for those athletes that play through it. So you will double your recovery time potentially by playing through your injury. Not only is it dangerous for you to do that, but the things that are tangible to athletes is it takes them longer to get better, and they feel much worse. So there's an 8 times higher likelihood of having more significant symptoms as far as the severity of symptoms by continuing to play afterwards. We need to ask about pre-existing problems that person has, previous headache disorders, learning disabilities, attention deficit disorder, previous depression or anxiety, as those things can overlap some of the symptoms of concussion. What about their prior concussion or mild traumatic brain injury history? The ones that they say, well, they weren't diagnosed by a doctor, so does that still count? Well, yes, if they got hit in their head, had the right mechanism, they had the appropriate symptoms afterwards that lingered for longer than just a couple brief seconds, those are certainly ones that we would need to consider in the history of concussion. And I also ask about their typical recovery course. That gives me a better idea as far as, is this kid having an extended recovery course with each one, which would make us more concerned about how their brain is responding to traumatic brain injuries, or have they all been fairly short-lived? And really, what have their symptoms done since the injury? So have they improved? Have they stayed the same? Have any worsened? Are they seeing anything that are particular triggers for making their symptoms worse? So those are important things to get through history taking. And I put symptom checklists on here because this is a very helpful tool if you're not utilizing it in the office to assess concussion. So this is an example of the post-concussive symptom scale. This is used for those age 13 and older. It's a 7-point Likert scale, so we use 0 to 6, so 0 being no symptoms, 1 to 2 being mild, 3 to 4 being moderate, and 5 to 6 being severe. So this is what we'll give our patients when they come into the office with us, and we'll have them fill this out before we go into the room. And the way we have them fill it out is they fill out one number for each of the symptoms there. We don't want to do the halves. It's amazing. I still get patients that we give them 7 choices of a number, and some people will still put kind of in between, or they'll circle 2 numbers. Just pick a number. I mean, there's 7 to pick from. It's not that hard. But I also ask them how they felt over the last 24 hours. And the reason why that's important is if they fill this out, how they feel at that exact time that you're talking to them, you're going to only get that little snippet of exactly how they've been feeling over that period of time, rather than the big spectrum of how they felt over a period of the day. Because you may get them at a good point and they may actually feel perfectly fine, and you'll get a false sense that, oh, they're not doing so bad. Or you may catch them at a really crummy point in the day, and you'll kind of kind of emphasize the severity of their symptoms that they're experiencing. So we kind of look at it in perspective over the course of the day, of the last 24 hours, and we will use this to frame our clinical interview. So I'll go through each of the individual symptoms that they list on here and ask them further details. So quality of their headache, where is their headache? Kids that have a lot of headaches towards the back part of their head, you need to be thinking about the neck as a contributing factor for their symptoms. And they may not endorse neck pain because they may not consider the back aspect of their head as part of their neck, but those neck muscles do attach there. And that can be a cervicogenic related headache that they're experiencing because of the neck injury with their concussion. So we need to be asking about that. And it's going to be very different as far as recommendations I may provide for somebody that tells me they're having a severe headache constantly throughout the day, as opposed to one that's there for 5 minutes and the rest of the day they're headache free. So those are 2 different spectrums of somebody who may be reporting severe headaches and how that's really affecting them throughout the day. So these are useful ways to follow patients. I don't encourage physicians giving these out and having athletes fill them out daily and then reporting back to them their daily symptoms. It gets kind of exhausting, and kids get kind of annoyed about asking about how they feel every single day. So, you may want to have them fill it out every couple of days or things like that. That's fine. I usually will actually just have my patients just report to me their trend of how they've been feeling over the course of a week, because I use actually email for my patients for follow-up on a weekly basis to start off with, and just give me a trend on how they're doing. But that's how I manage things in my office with my patients. And then there is a scale that's designed for ages 5 to 12, so it's only a 0 to 3 Likert scale, and they put things into small sentences to kind of explain things at a more age-appropriate reading pattern for 5 to 12-year-olds. So this is what we'll typically use for that age group. So putting some other things on here, and I'm not going to go into details about these because these are things you can look up online. There's videos for all of these types of things there, and you can get more detailed about them because these can honestly be individual full long hour talks going through the nitty gritty of each of these assessments. But there is what's called a balance error scoring system. So what we do there is we're going to have a person do 3 different assessments where we have them do things with their eyes closed. We start them with their feet together, hands on their hips, eyes closed, and we're assessing for errors that they may make. And that can be something like raising a hand off of their hip, opening their eyes, leaning too far to one side, moving a foot as an example. Those are all types of things that would be considered an error. And we count those up over the course of 20 seconds. You can have a maximum of 10 errors per the 20 seconds. So we start off with feet together. Then we have them start off by, we ask them what leg they would kick a ball with. They're going to lift that knee up and stand on their non-kicking leg. and we do the same thing with their eyes closed, hand on their hip for another 20 seconds. And then we'll do a final one where we do a tandem stance where we have them put their kicking foot in front of their non-kicking foot, almost like they're on a tightrope. And then we do the same thing, hands on the hips, eyes closed, assess them for 20 seconds and look for errors. That's the modified version of it. The complete best, that's actually been looked at in research. They also will do the same thing, and they put the patients on a 10-centimeter thick piece of foam, which I don't know many people that are going to want to have that around in their office. So the vast majority of us will do the modified version, which is the non-foam version of it. And that's perfectly adequate to assess. And that can see if they have some balance troubles, which may suggest they have a vestibular problem. And that may be something we can do some physical therapy for. And then there's the VOMS, the vestibular ocular motor screen. This looks at different ways of how the eyes move and eye assessments. And we're looking for dysfunction of the oculomotor system that could be a cause, which also could trigger some ocular symptoms, which may require us to do some specific therapy for ocular motor rehab, as an example. And then we definitely need to make sure we're assessing the neck, assessing for range of motion, and does it cause any pain, and do they have any spinal tenderness, especially if they have midline tenderness. That's someone you're going to want to consider probably getting some x-rays of their neck, as opposed to just the paraspinal pain. So some red flags here. This is the red flags in the sideline assessment. I'm going to highlight a few of these here that are ones that for us typically would make us trigger wanting a kid to get sent in to get further imaging. So the neck pain or tenderness, obviously that's a concern if they have midline tenderness, and if that kid has got hit and they're down, we're going to probably immobilize that person's neck rather than risk things. Double vision also is one that it's common to have ocular motor issues and have some double vision, but that wouldn't be a red flag for me for someone to need to get a scan. But weakness or tingling, burning in the arms or legs, that's a concern that we would want to consider sending that person in for a scan. And typically it's going to be a CT scan. The severe progressively increasing headache, the one that's the worst headache of their life, that's always a concern, especially if it's not resolving or improving. Loss of consciousness, the literature, 30 seconds is used as considered a prolonged loss of consciousness, but I don't know anyone that's at a sporting event that's waiting with a stopwatch and hitting start when they see someone go down, and then counting from there, and honestly being involved with some of these athletes on the sidelines. 30 seconds of loss of consciousness can seem like minutes to dozens of minutes. It can seem like it's lasting a lot longer than it really is. So it's hard to put that in perspective. If they're having deteriorating state of consciousness, that's a concern. Repetitive vomiting, and I use the 2 puke rule. So if they've thrown up more than twice, they probably need to get seen, especially if that's in the acute setting. And increasingly restless, agitated, or combative, those are all, to me, red flags to consider imaging for. The seizure or convulsion, that when they've looked at this from a standpoint of, do we find things intracranially for seizures or convulsions post-traumatic, that oftentimes does not correlate with the severity of the injury. So it freaks everybody out, so it's a concern, but it wouldn't be something that to me would be a trigger to get imaging on. So we want to think about neuroimaging in patients that have red flag positive findings there. CT scan is what's typically ordered, as I mentioned. Also, an abnormal neurologic exam may be a trigger as well. An example I give is a 10-year-old I saw years ago now who came into me actually 3 months after their concussion. They had been seen by their primary care physician, had been cleared to actually go back to hockey because this kid was a hockey player. And the parents came into me because the kid was on the ice and he was just really having trouble maintaining balance on his skates, which was never a problem with him before the concussion. So I evaluated him, did an exam on him, and 2 things that were very significant findings on his neurologic exam. We had him to do finger to nose, and he could not hit his nose to save his life. He was hitting his forehead, his cheeks, his chin. He couldn't touch his nose at all. So that was already a red flag to me. And then when I had him do a tandem gait, so like walking on the tightrope, when he would do that on his right side, he would bring his leg way out to the side and then bring it back in rather than just kind of keeping it close to his body. So it was a really awkward tandem gait. So that was a big concern for me on his exam, especially with those reports of balance. So we actually sent him for an MRI, and he actually, lo and behold, had a brain tumor. He's the only kid I've diagnosed in almost 20 years of doing this who had a brain tumor, but he clearly had some abnormal things that did not make sense and were abnormal on his physical exam, which triggered us to look at that. Most neuroimaging in sports concussions is low yield, so we don't typically recommend those. We have to remember that there is radiation involved with CT scans, so we don't want to just do them willy-nilly or just to look or to rule out a concussion, because you're never going to see a concussion on a CAT scan. We're only going to see things like just skull fractures or brain bleeds, and we actually know some criteria that can help us kind of triage that. So there is what are called the PCARN criteria. If you do PCARN, PECARN, these were done through ER network, multi-center, and have been replicated many times now. And these are shown to be good, valid criteria as far as who really does need a scan. So the first, that's the automatic trigger there. If they have a Glasgow Coma scale less than 15, so 14 or under, or other signs of altered mental status, or they have any signs of a basal or skull fracture. So those are things that would be ones that a CT scan is recommended. Now, that accounted in this particular study that I reference here to 14% of the patients. And in that particular cohort of patients, only 4.3% had a clinically significant finding on their imaging. However, again, that was a higher than the other population. So that was using those couple criteria, they stratified those out as ones that would be more likely to need a CT scan. Still unlikely to find something there in the vast majority of patients, 95+%, but that was a higher risk. If they don't have that, then if they had a history of a loss of consciousness, history of vomiting, severe mechanism injury, and those usually are not our sports-related injuries, or a severe headache, and they have a yes, you can go down the route of observing them to start off with, which is what a lot of the children's hospitals do, versus getting a CT scan. They'll observe them for 4 hours, and then they will make a decision at that point whether CT scan is necessary. That accounted for a quarter of the population. And in that particular group, only 0.8% had some finding on imaging. And if they did not have those, CT is not recommended. That accounted for over half the population and a very small risk of any sort of clinically significant finding on imaging, 0.05% less than that. So again, if they don't have those things, the need for imaging is not necessary in the vast majority of patients. We don't get them for things like blurry vision. We don't get them for things like they're dizzy. Those are things that would not be triggers, although I see those unfortunately done frequently for those findings. But if you go by the PCARN criteria, you're going to save a lot of expense for CT scans for families and also unnecessary radiation to the kid's head. We're going to go through these individual things here as far as management, so medications and supplements, talk about screen time, sleep, talking about return to learn in school, how do we manage exercise, getting back to athletics, and we'll touch on driving as well after concussions. So it is okay to use acetaminophen or ibuprofen after the initial evaluation for concussion. If there's no concerning findings on exam, there's not really any great evidence to show that either of those medications either alter the recovery course or that they affect things that make it a more severe injury. So I do caution using ibuprofen in patients that are reporting a lot of nausea. We don't want to upset their stomach more. I'm not a fan of doing the every 4 to 6 hours rotating medicines. We don't tend to find that that helps. The vast majority of patients that I see that have been put on that recommendation, they come in and they tell me it doesn't help. And we do need to be cognizant of medication overuse headaches. That has definitely been reported with both of those medicines, including in patients after concussions and traumatic brain injuries. So I don't recommend scheduling them. And just like anything else in medicine, if we use it and it's not helping, have them stop it. So we always want to do something, and oftentimes medicine's the lowest hanging fruit there. But if it's not helping, don't keep having them take it just for the sake of taking it. So the nice thing about those medicines, they don't need to build up in your system to get the effect. They're either going to help or they're not. And if they don't, we stop. And I tell them that's kind of my expectation. I don't tend to find that they're very helpful. There's really no research to date that demonstrates any consistent benefit of symptom improvement or the time to recovery with any supplement or medication that's out there for sports-related concussion. And this has been researched a little bit more lately. There's not a lot of research, even probably 5 years ago. There's been a couple more things that have been researched, but they really haven't shown any consistent benefit. I do tend to recommend melatonin a little bit for sleep initiation if it becomes an issue, but that's the one thing that I use. And I've gone through phases with my concussion management. Obviously, 20 years ago, the recommendation was the complete cognitive and physical rest, which we don't do that anymore. And then progressing from there to doing a lot of medicines is something to do, and then realizing that that wasn't very productive. And now we do more of a kind of an active way of rehabilitating someone after their concussion. We'll talk about that specifics. So I'm going to talk about screen time because this is a question that comes up frequently, and I still see recommendations all the time. Don't use screens at all. There is no contraindication to using screens after a concussion. They do not worsen your recovery. They do not make your symptoms significantly worse, that it's actually injuring your brain more. So this is one study that was looked at based out of the ER. They used a population of concussed people 20 or 12 to 25. They put them into two groups to randomize them, and they had what was called the screen time abstinent group, which is a little bit of a misnomer that we'll talk about, and then a screen time permitted group, and they said you didn't have to worry about reducing any screen time. And they monitored them until they had a day of using those symptom checklists that the score was less than 3. They also used cutoff of 6 or 7. So let me explain that a little bit if you're not familiar with those and how that's used in concussion world. And there's still debate about this for those of us that deal with concussions as far as whether those are valid assessments. So when we look at a concussion and we fill out the symptom score, we total up those numbers and we have a number on there. When we look at that, they've shown in some research, some people will use the cutoff score of 6 or 7 of considering that person recovered. Now, I would argue about that because if I have someone that comes in, they consistently are still reporting a headache at a 3 throughout the day and difficulty concentrating at a 3. Well, that's a 6. That person to me doesn't sound like they fully recovered if those things are still a problem for them, especially if they weren't there pre-existing. So we have to take that with a little grain of salt when we're using these symptom cutoff criteria as far as considering recovered. And the problem with this study is they stopped following them after this. So going back to what I talked about symptom scores, if they got someone on a weekend day, they may actually feel pretty good and their symptom scores may be low. And then they go back to school and their symptoms flare up because of increased cognitive demand, and pushing through stuff, things like that. And in that sort of situation there, well, that patient would not be, in our book, considered recovered, but they may have been considered recovered by this study. So we have to, again, take that with a little grain of salt. But what they did is they advised them no work or school for the first 48 hours, and they were told for the abstinent group to abstain from screen use for the first 48 hours. So what did they find? Well, first red flag in this study here is they lost 25% of their population cohort in each of the groups. And this was patients that were followed for a week and a half to 2 weeks. So that's already a concern for me, that why did we lose so many in such a short study? From following someone over years, that's a different story. And half of the concussion patients here were from sports, so we have some other groups that are in here, so we can't apply this just to a sport-related concussion. But what did they find? So the screen time permitted group, they recovered in a median of 8 days. The screen abstinent group did improve quicker. They were considered recovered after 3.5 days. But this is the part that caused me some pause of, can we really say that that's truly the case? So when they talked about returning them to school or work, the screen permitted group was back in 7 days, the screen abstinent group 1 day sooner at 6 days. So if they're recovered at 3.5 days, why did they have 2.5 more days to get back to school or work? That doesn't make a lot of sense in that sort of situation. And then exercise, that one I don't worry about as much, because usually we're not providing recommendations for exercise out of the ER, but same story there. It was 1 day shorter in the screen abstinent group as opposed to the screen permitted group. So I don't know how much we can take of this. I did review a study recently that has not been published yet, but it did show actually that there is a sweet spot as far as the amount of screen time. So the lowest 25th percentile screen time use and the highest 25th percentile screen time use in the study that they did, those are the patients that did the worst. And the patients that were in the middle, the 25th to 75th percentile, those patients actually had the least amount of symptoms and recovered the quickest. So there is kind of this Goldilocks, this just right phenomenon. So not too hot, not too cold, but just right as far as screen time use in that particular group. But interestingly, when we talk about the screen use, the median screen use for the screen permitted group was over 13 hours per day. And the 75th percentile was at 990 minutes. I don't know how you can possibly be using that much screen in a day and still function. So it's interesting because these were self-reported screen time use. How much of that was being used? What types of screens? What type of activity were they doing on the screens? Even the screen absent group at a median, they were still using screens for over 2 hours a day. And then the 25th to 75th percentile was anywhere between an hour and 4 hours. So we have to remember they're not staying off the screens entirely. So I would call this a screen time reduced group rather than a screen time abstinent group, because it really isn't a proper term that they were totally abstinent from screens in this study. So the thing that I would tell people, it's not the smoking gun here. So, just eliminating screen time is not going to be the way that everybody's going to get better. Moderation is the best. And if you are providers who are referring to me and you're still recommending screen time, complete resolution or complete holding off on that, your patients love me a lot more, because when I see them in the office, we do let them start to use screen time. So you can let them use it, but again, if they start having a flare up of their symptoms, they back off, they rest, they can come back to it. We don't need to eliminate it completely. And like other stressors, again, we're taking a break. And we don't want to use concussion as a punishment from electronics. These kids are already stressed out enough if they're athletes because we can't tell them exactly when they're going to get back to sports. And so they're already stressed out about missing sports. They're stressed out because they may be getting recommendations to stay out of school. So again, moderation is best here. We don't want to, do too much screen time. We don't want to do no screen time. It's okay to use the screen after concussion. It's not going to make the actual brain injury worse in this picture. So let's talk a little bit about sleep. We already know our kids and teens have poor sleep habits. Numerous studies actually demonstrate the negative influence of too much and too little sleep on concussion recovery and symptoms. So that can be a big modifier there. So we really need to touch on sleep with these kids. And we talk about things a lot in the office about consistency with their sleep schedules. We want them to have a consistent bedtime and wake up time. We don't want to be doing lots of napping throughout the day. I see a lot of kids who are what I call sleep zombies in my office because they're kept home from school. So what do? And they're told they can't do anything. So they sleep for 12, 14 hours a day. That's not what we want for those kids after concussions. And when we're in that sleep environment, just like good sleep hygiene, we want no distractions in the room. So we want their phones to not be going off at 2, 3 in the morning. That's distracting them. We prefer not to have TV screens going on because that can be distracting to them to get good sleep. And as we should be talking about all of our kids as far as what the bed is really for, it should be for not lounging around or doing your homework in. It's really the place for sleep because otherwise your body gets confused messages of what is this place for. And we need to remember that most of the kids that we're dealing with concussions in sports, 8 to 9 hours of sleep is their typical recommended duration for our preteens and teens. And it may be even up to 10 hours for our younger grade school age kids. So talking about return to learn. So one thing I would highly make sure and stress here is we really want to avoid restrictive notes that are not going to benefit the student. So statements that have lots of no's in them, no reading, no tests, no homeworks, those are things you should absolutely not do. Because what that does is it really pigeonholes the school as far as what supports they can offer. Because once they get that back from the doctor, they really have to do that. And there's nothing wrong with doing some homework. There's nothing wrong with doing tests with adjustments. There's nothing wrong with doing reading. Okay, so those are all things, but again, we need to do that in moderation. There's a study I sometimes will present that shows that when they looked at kind of cognitive load, the kids who did the worst were the kids that weren't backing off at all. They're doing their normal workload, and those are the high achieving students that I worry about the most that don't know how to pull back the reins. But if you looked at the kids who had no cognitive activity at all compared to ones that had just some reduction from their normal load, the ones that had just a somewhat reduction recovered just as quickly as the kids that stopped altogether. So we don't need to go to the extreme of not having them do any schoolwork at all. We just need to reduce it. And I encourage you to make sure you're checking, having kids check back in before we start things like return to play. And we'll talk more about that in a second. So one of the key questions that I use is, are they feeling, and this is a typo here, is your child or are they feeling, if I'm asking them directly, 100% back to their normal self in and out of school? And if not, what's not back to normal? That gives me a better idea as far as what's going on. We don't want to use the question of, are you headache free alone as the one symptom that we're looking at, because they may be headache free, but they may still be having really lots of challenges with dizziness or troubles focusing or concentrating that wasn't there pre-existing. And that kid is not a kid that we're going to start on the return to play progression. So one thing I stress with patients in my office is that using your brain is not going to worsen the brain injury. An analogy I give them is, I've never seen a kid come into my office who got a concussion from doing too much schoolwork. We know that the brain's not functioning at 100% after the concussion. I'll give you a little analogy in just a second. But it isn't going to harm the brain or make the concussion actually worse. We're not going to damage the brain more by using it. We just need to remember it's not functioning at 100%. So we need to account for that and reduce, not eliminate, not worry about that. Again, the concussion is going to get worse by doing that, by doing some level of schoolwork. It may increase their symptoms, but it's not going to further damage the brain. We encourage kids during the school year to communicate with their teachers about how they're feeling, because again, it's not an outwardly visible problem. We can't see the vast majority of their symptoms that they're experiencing. So if they're not disclosing that to people, then teachers don't know what troubles they're dealing with to be able to help make proper adjustments throughout the school day. And again, as I've mentioned before, moderation seems to be best with this, with breaks as your symptoms worsen. But the symptoms worsen again, that's not an indicator that the concussion is worsening. It's just your body's telling you, I've reached my limit. It's no different than if you had a knee problem and you start running more and then you reach a point where your knee starts hurting more. Well, it's not that you're damaging your knee further. Your body's just giving you feedback that, hey, this is my limit for this right now, and I need to address this. And I really would discourage physicians from requesting 504 IEP plans, especially early on. Once you request that as a physician, the school is mandated to go through their 504 and IEP programs to put those into effect, which is a huge amount of school resources to do that for each individual kid. And it's not going to make the 504 pop up in a matter of a short period of time. As personal experience with a kid who had anxiety when he was in grade school, going to middle school, our 504 plan took us weeks to actually get that put into place for him. And that was through lots of input from all of his teachers. So if we think that's going to happen in the concussion quickly, it's not. And by then, the kid may be feeling perfectly fine. So we've really drained the school's resources for an unnecessary request. So this is an analogy I like to use a lot, and I stole this from Karen McAvoy, who's a colleague of mine, who's a school psychologist that I've worked with a lot in the world of return to learn. So when you are not concussed, your brain is functioning like the iPhone 13 Pro. Okay, it's got all the new apps, it's got all the fancy processor to go really fast, it's got the fancy camera, so everything's really focused and sharp and in working the best and gives you the best clear pictures. But when you're concussed, it's like you're the iPhone 8. So the iPhone 8 still functions. It still runs the apps that the iPhone 13 does for the most part. It just doesn't run them as quickly. It may not have all the fancy features, but it can still get the job done. That's the brain on concussion. So it can still get the job done. We just need to account for the fact that it's going to take it a little bit longer, and it may cause us a little frustration as it's taking a little bit longer to get through it that the iPhone 13 Pro can do quickly. So we're not going to damage the iPhone 8 by making it work. Okay, so and the battery may wear out a little bit quicker, so we may need to recharge it a little bit sooner. So that's where some brakes get built in. So I find that to be a helpful analogy, and I use that from her because I think it really puts into perspective as far as how we need to think about the brain functioning after. So I'm not going to go into details about each of these studies here, but these are just some of the studies that have been published just this year alone that show the benefit of light physical activity in someone who's recovering from concussion. So where does this really go wrong? Because I know a lot of providers are starting to recommend physical activity, which is good, but we need to be really explicit about how we're recommending that to patients. So what that means is we should be doing what's called sub-symptom threshold training. So if they're going to go out and do some very light cardio, and I'll define that for you in just a second, we need to make sure that they're not pushing through things that are worsening their symptoms. So they have to keep it at a lower level. It's not going back to their sports practices. It's not starting sports skills. It's just doing some level of cardiovascular activity, which is where all this research has been done to show that it's actually beneficial for someone's recovery, doing some light cardio that's not provoking symptoms. And actually patients get better quicker and they have less symptoms in those that we are doing this with. We also know from some of this research that the kids that are not tolerating exercise as well with this light symptom threshold training, those kids do tend to take a little bit longer to recover. So what do I recommend in the office for patients to make it simple? I tell them they can start with 20 minutes of either brisk walking, so like they're late for class pace of walking, or we have them do using a exercise bike, not a regular bike, because some of these kids have some balance issues. And we have them do up to 20 minutes, but stopping for that day if they have any symptoms that get worse that they had at the start, or any symptoms that pop up that weren't there, and then we'll try again the next day. We want to try them to do it each day. If they're tolerating that for a week at 20 minutes, then I'll increase them to 30 minutes, still doing the same intensity. So there is a published treadmill test that you can use, but I don't know many people that have access to that. I'm not going to send someone to the physical therapist just to assess their cardio intensity that we can do exercise at. You can keep them in this simple framework of this light exercise bike or brisk walking, or even sometimes a little bit of a light jog. And again, we want to encourage them doing that daily, but we need to be clear about the instructions, because the other converse of that is we see a lot of patients that are discharged from their primary care doctors with also the published return to play progression. And a lot of patients start to interpret that and they start working their way up the return to play progression when they really shouldn't be on that yet. So how do we get them back to sports? They need to be back to being symptom-free at rest. And that means what they were like before they had trouble. So they 100% back to normal, the way they felt before their concussion. They may still have some symptoms that they report on the checklist because they had those before. So kids that have pre-existing sleep issues, kids that have learning disabilities, ADHD, they're never going to put a 0 for difficulty concentrating in all likelihood. So as long as those were the exact same way they were pre-existing from their concussion, that to us is considered they're back to their baseline from a standpoint of their symptoms. So this is where the symptom checklist can be helpful. We're going to gradually increase their physical exertion. They should not have a return of symptoms with exertion. They should be performing at their pre-injury level in school. Now we're in the summer. We're going to be going to a time where we may have a few select kids in summer school, so we may not have that school assessment to be able to use, but that doesn't mean they need to be caught up with all their schoolwork. It just means that they need to be performing at their pre-injury level. They need to be off medicines that may have been used to control their acute symptoms. And again, we just need to account for these pre-existing issues that may modify their symptom level or their symptom that they're experiencing. So this is an example of the return to play progression. Again, we don't start this until they have gotten to the point where they're symptom free. So it's a 1 step per day. So the step 1 has really now been replaced by doing some of this light sub-symptom training rather than the no activity at all. And then we kind of work our way up from there. So step 2 is we're going to increase their intensity of their aerobic exercise. Step 3, we may add some sport specific type training in there or some sport specific movements. And then we may go back to normal training drills just without contact if their sport involves contact. And then the final step would be going back to a full unrestricted practice. We put contact in there. Obviously, not every sport involves contact, and kids can get concussions in those sports as well. But they need to complete a full contact practice. So what that means for football, as an example, a walkthrough on Thursday does not count as a full contact practice. They have to have done a full unrestricted practice. And it may not involve contact that day, but a walkthrough does not count. So this is where a football player who gets a concussion on Friday night, if they're not totally symptom free when they would see in the office on Monday, they are not going to be able to progress through this to be able to get back to play the following Friday. And I stress my favorite poster that I've ever seen in locker rooms after concussion is one that said it's better to miss a game than miss a season. And I wholeheartedly agree with that. So I'm always going to be a little bit more conservative when it comes to a brain injury than I am something else potentially. So just to touch briefly on non-sport concussions, we need to remember these don't just happen in sports, but the sports get all the attention. They can happen from playground injuries, PE class, bullying events, falls, domestic violence, can happen from motor vehicle accidents. So the same principles apply here for these injuries as they do for sports-related concussions, but there is potential need for more psychosocial therapies for those that are involving significant trauma like bullying or domestic violence, and even the trauma of having been in a motor vehicle accident, especially if it's a new driver, and the stress that comes around with that. And when we talk about returning to play, that could be even things like PE, recess, or recreational activities. We do want to follow the sports lead. It is best practice to put them through some increasing level of exertion before we let them go back to full unrestricted PE or recess or recreational activities. We just need to be a little creative about how we use those return to play guidance for that. So some management don'ts. We don't recommend cocooning. That's putting someone in a dark room and not having them come out until they're symptom free. In fact, we actually kind of discourage dark rooms on a routine basis anyways. I find that can disrupt some of their sleep schedules because of their lack of exposure to the sunlight, which is a trigger for our body to know when's night and day. I tend to find also that lots of use of a dark room tends to increase kids' sensitivity to light. So again, it's okay to lower the lighting some, but we don't want to have kids in the dark room all the time. We really don't want to recommend prolonged absences from school. So if you're giving recommendations to kids, don't go back to school until you're symptom free or until your headache's gone. Please stop. We can have them back to school after a day or two off, and there is research to show that kids that are back to school in their school environment with adequate adjustments from their school compared to kids that are staying home for a week, the kids that actually are back at school get better quicker and they have less symptoms than the ones that are staying home. We do not need to routinely wake kids at night if we're giving those recommendations. If we're that worried that we're going to have a parent basically do a neuro check at nighttime, that you're that concerned that you're going to recommend that to someone who's not medically trained, probably we need to send that person in to get further observation in the hospital or the ER. We don't want to overlook driving recommendations. So we know that kids have delayed reaction time after concussion. They've done some research studies on adults that present to an emergency department who have been concussed compared to things like an orthopedic injury, and they put them in driving simulators, and the people that have concussions have a much more difficult time navigating those hazards if they're concussed compared to the ones that have the orthopedic injury. So we need to consider them as being an impaired driver. So oftentimes for that first week, at least, I don't have them behind the wheel. I would really discourage you from putting labels on mild or severe with concussions because there's no evidence base to say that. You sometimes can downplay the injury as being a brain injury by calling it mild. I see kids, oh, I've had several mild concussions. Well, you've had several brain injuries. We need to remember that. And the same thing for severe, that can create some unnecessary expectations as far as how bad the injury may be, or expectations for the patient as far as what their recovery may be. Oh, it's a severe concussion, this is going to take a long time to get better, kind of thing. And there's no way to judge that in advance. So we really just tell people you're either concussed or you're not. We don't put descriptors on there because, like I said, it sometimes either downplays the injury or it overplays the injury, and sometimes creates some wrong expectations for families. Because we tell them, well, it's a mild concussion, they're taking 6 weeks to get better. Well, why did it take so long? This was mild, so to speak. And if you are giving your handouts about return to play progression, please make sure you're giving them very explicit instructions on when they start and how they go through it, because way too many patients come into my office and they say, this is given by the doctor. I started this, they started it at an inappropriate time, and they're not following the directions because they really weren't given any clear instructions outside of the handout that was given. So it's really important to talk about them a little bit, because what people are getting out is not clear to patients. So some overlooked causes of prolonged recovery. These are all things we need to think about. So coexisting neck injuries, super common after concussions. We have to be aware of that as also a contributor to headaches. The kids that I see that have a lot of headaches towards the back of their head, kids that are telling me they're having consistent headaches that are there constantly throughout the day, the neck is oftentimes a contributing factor to those. So we want to assess for that. And kids that have that, I'm very aggressive sending them to physical therapy early on to work on some neck rehabilitation. We need to remember that some of the things that we do could cause depression or anxiety based on, the fact that these kids are restricted from things, and some of those things pre-existing also could cause trouble. Sometimes kids will start looking at things on the internet about their concussions. That freaks them out. I've had patients that that's happened to. And certainly we need to account for the fact that just being out of their normal social kind of regular environment sometimes can lead to some depression as well. And sometimes because it's not an outwardly visible injury, people don't believe them. And that's frustrating to patients as well. And that can lead to some depression or anxiety about their injury. And that can obviously magnify some of their symptoms because some of those symptoms overlap concussion. We may see vestibular injuries. That's where things like the balance error scoring system, talking more about dizziness, feeling off balance, may be an indicator of that. And that may be something we need to send to physical therapy. Ocular motor issues, those definitely we see that could cause some kids some prolonged problems, getting disrupted in their sleep schedule, which is why we talk about all these things. Some kids that may have had an undiagnosed migraine problem can start to get a chronic daily migraine picture after traumatic brain injury, so we see that as well. And then I put malingering on here. I don't tend to find this as much of an issue for our kids that are having concussions from sports, but if they are something like a bullying event or a domestic violence event, those are things that could cause this PTSD-like kind of problem, and they may want to not be back in that environment, and they may kind of linger on to some of the things that are being recommended, but not doing this as a way to be able to stay out of that environment, and they may magnify some of their symptoms. And I've had that happen on occasion with some kids that have been had concussions as a bullying event. So we need to be aware of that and asking about that. So I mentioned earlier the iatrogenic worsening of concussion. So we have the initial injury, we prescribe rest and activity restrictions, which can lead to deconditioning, which can lead to mood changes, stress, anxiety-related activity withdrawal, which then causes symptoms to increase in some situations. So additional rest is recommended, so that continues to worsen their symptoms, and we just create this bad spiral of problems here. So we're not doing this sit around, do nothing approach anymore, meaning no school, no physical exertion at all. We're doing some level of light cardio. We're doing some schoolwork, but we're having some breaks put in there. We're giving additional time to get things done, but still letting the brain work. So we're trying to keep as normal as possible, trying to minimize significant flares of symptoms, but it is okay to do some of that light stuff like we talked about. So if we keep doing the prescribed resting, that definitely can lead to this worsening of symptoms, and I see that a lot. So we like to use the word persistent symptoms of concussion rather than the term post-concussive syndrome. I see a lot of kids who are diagnosed with post-concussive syndrome after they've had their concussion for 3 days, and that's the diagnosis they were given. That's not what post-concussive syndrome was initially described at. It was patients who had symptoms that lasted longer than 3 months, and it used to be in the DSM-4 book. The most recent DSM, it took post-concussive syndrome out of it as a diagnosis. But it's really our preferred term is the persistent symptoms of concussion for those that have prolonged symptoms longer than 6 weeks. So that could be, if we just look at statistics here, 50% of kids that have sports-related concussions typically are back to feeling their normal self within a week to 10 days, but that also means 50% are not. About 3/4 of patients, usually by 4 weeks, are feeling back to their normal self. And then there are about that 5 or 10% that have some lingering issues beyond 6 weeks. That's why we need to go back and look at some of those things that I talked about that could cause prolonged recovery, and address those as appropriate if they have not been identified or addressed previously, because that oftentimes can help those kids that are lingering. So we need, again, get rid of that post-concussive syndrome out of your vocabulary, because it's really not a term we use in the concussion world any longer. Protective ear is really likely not going to be a savior. Mouth guards, there's really been no proven benefit, although any dentist or orthodontist will talk to you about the benefit for protecting teeth. So if obviously there's a lot of contact, we are strongly recommending mouth guards for the benefit of protecting their teeth, and certainly braces. Helmets, the 3 most common sports in boys with sports with concussions all use helmets. So football, ice hockey, and lacrosse. So if helmets were the savior here, those should not be our 3 highest sports for concussion rates. So the helmets are great for protecting against skull fractures and subdural hematomas, epidural hematomas, but they're not very good as far as reducing concussion. If you think about it, just simple physics, we have a natural helmet already. That's our skull. The brain is sloshing around inside. We put another skull on top of that, so to speak. Well, if you get hit, the brain still can slosh around in the skull. So from a physics standpoint, the only way we're going to prevent that moving around of the brain in the skull is to have something internal, which I don't know anybody that's going to do that for the sake of preventing a concussion. So helmets are probably not going to be our big savior. It is important to make sure that kids are getting them fit properly. That's really, really important with this, and getting them refurbished if they're using helmets, especially after they've been damaged throughout a season. You don't dispose of them like bike helmets after bike helmets get cracked. But there are refurbishing and certification programs for helmets. So it is important for patients to be asking their teams about how are they being done. Most of the high schools are doing that for their helmets, but that may not be done at a younger level. Headgear, like soccer headgear as an example, there's really limited data demonstrating benefit of those. One thing that we need to be aware of, there is a study that suggested they put kids heading a soccer ball with headgear on and without headgear, and the kids that actually had the headgear on significantly headed the ball harder. So when we talk about this gladiator effect, we put more protective gear on so people feel that they're more protected. Does that negate any benefit of it, or are these things really just not helping at all? So we need to think about that when we start just adding more stuff. And I've actually seen kids who have been victims of targeting, where kids who are wearing headgear in sports like soccer or basketball, volleyball, who have had repetitive concussions, or parents are concerned about that because they bought into the world of headgear, that coaches have encouraged some, and this has happened, have encouraged their players to basically target and try and be a little bit rougher on those kids that have the headgear on, because they know why those kids are wearing headgear is because probably they've had previous concussions. And what a better way, unfortunately, to take that kid out than to be a little bit more rough on them. So retirement from sports. So I put this slide up here from the old Schoolhouse Rock. The 3 is the magic number. 3 is not the magic number. So there is no magic number that we use. We have to individualize this. So if you are considering recommending to a patient that they should retire from sports, regardless of whether it's just one sport or multiple sports, I would encourage you to have them seek out guidance from a specialist in concussion, and that could be a neurologist, someone like myself in sports concussions, rather than just jumping to that, because they may not necessarily need that. Our biggest concern, honestly, is the repetitive blows to the head that don't produce concussion. That's the thing that's been felt to be the biggest leading contributor to long-term brain injury that we see in some athletes that have played sports for decades. But in the big picture of things, 3 concussions by themselves, especially if they're isolated concussions, they recover quickly. That would not be someone that I would be telling my kids that, hey, now you need to stop sports altogether. So there's lots of things that we look at and we have discussions about with those patients. So I would discourage you from using one number as the magic number. And then, as with any talk I've given to primary care providers this year, this was a promise I made on social media, so I'm going to keep that promise. The value of athletic trainers. They are not personal trainers. They're not just someone that's there to tape you up. They really honestly have a broader grasp of the most musculoskeletal problems that most physicians do. They really can be strong advocates for us for our primary care prevention efforts in the schools. And they do understand and can conduct the concussion return to play progression. So if you know kids that are at the high schools that your kids are going back to after you've recovered, or if they've been recovered, you can utilize them to help supervise this return to play progression. So we want them to be seeing their athletic trainers to do that. And they are super helpful for me, as they are my eyes and ears that I can't see and hear about all the time. I get stories from athletic trainers who call me and tell me, hey, so-and-so has been talking to the other teammate in their locker room that they're saying they're still having headaches even though they told you they were symptom free. So if you do get a call from an athletic trainer, because I encourage them to reach out to you guys if they're hearing that and they've gotten clearance notes from you, be receptive to them, be kind to them, listen to what they have to say, because they do probably have that knowledge that we're not getting, because lo and behold, athletes do lie to us on a not infrequent basis about how they're feeling because of their desire to play, not to let coaches down, not to let parents down. So work with them and be partners with them, because they really are helpful adjuncts to us as clinicians out in the sports world, in the sports setting. I'm going to put my shameless plug in for my podcast. So I do host a podcast, the Pediatric Sports Medicine Podcast. We cover all sorts of sports topics, both in the world of musculoskeletal care and then non-musculoskeletal care. So you can download this from any of your podcast streaming platforms. I've been doing it for the last 2.5 years, and it's a lot of fun. And I get a lot of good feedback from providers who listen to it. And then any questions? If you do, obviously, since this is done remotely, feel free to reach out, and you can email me at the address that's on the screen here. Those are my Twitter handles there for my personal one, which is St. Louis Sports Med, and then the two podcasts that I host. The Ped Sports Pod is the main one. So feel free to reach out if you have questions on this particular talk, and thanks for your attention.